Thank you. I won't be taking much time in explaining about the program. I would like to convey my wholehearted thank you for all the nominations from all these institutions present here. I have been receiving letters and emails from most of you, and thank you so much for showing interest in learning and being a part of this program. So happy to see the places from where you all represent. Usually we get people predominantly from southern part of India, but this time it is from everywhere. So that's quite exciting for us too. Thank you so much. As Sripriya told, we are really looking forward to you all as an integral part of improving access to palliative care to so many million patients in the country. Thank you so much. Today we will start with a little bit of introduction. Many of you might be familiar with palliative care, but this is take it as a discussion to come into a common ground where we can take your views, your comments, and share our comments for today. Today we have Dr. Rajagopal as our faculty. Dr. Rajagopal is the chairman emeritus of Palliative India, and he's the director of TIPS. TIPS is the training and the demonstration center of Palliative India, which is a WHO collaborating center for training and policy on access to pain relief. Dr. Rajagopal has played a major role in various policy changes in the state and across the country, including improving access to opioids. He has been awarded with the Human Rights Watch Award in 2014, and in 2018, he was awarded Padma Shri by the Republic of India. There is an interesting book written by him in 2022. We published it. It is called Walk with the Weary. I think some of you or most of you will take some time out to buy and read those stories. This book, which is based on the experience with patients in his professional journey. Thank you so much, sir, for being a part of this program and to take the first session for us. Over to you, sir.
Hello, everybody. Good to see you all.
Hello, good evening, sir.
Good to see.
Good evening, sir.
Good evening, sir.
Hi. Majority are black screens indicating sorrow, grief, or not very nice emotions. So could you please set your videos on, please? We need to connect as human beings. Phenomenal. Very good. So many. Thank you. So, Sridevi, were you saying that we are going to have an introduction of the participants?
So that will take a little longer because we have almost nearly 70 participants joining today's session. We'll be going to the session directly.
That is sad. Such an opportunity to get to know everybody, and we are losing that opportunity. Okay, I see your point. So, friends, I hope time will provide us an opportunity to see each other at least virtually and get to know everyone. I know that you are from different parts of the country, but what is common and binding to all is that you are all medical teachers. Is that right? All of you. I hope you, I'm sure some of you were nominated, some may have come based on your interest. I hope by the time we have concluded the session, you will all have some interest in the subject, even if you have come in here just because you were nominated by the institution. I know that some of you have had an exposure to palliative care. Some of you have already had some training in palliative care. How many have had some training? Would you raise your hands virtually? Dr. Priya, yours is the only hand that seems to have gone up. Dr. Suraj. Suraj, right? Not Suraj.
Yes, sir.
Okay.
Hello, sir.
Yes, hi. So Dr. Suraj and Dr. Priya, you are the only two people who have indicated that you have already. There is Shahada. Shahada? Is that right? Hey, please unmute and tell me your name. How you pronounce it? Shahada?
Yes, sir. Good morning, sir. Good
Hi,
afternoon, sir.
good afternoon. How do you
I'm
pronounce your
Dr.
name?
Shahida.
Shahida. Okay. Where are you
Shahida
from?
Parveen from Kakinada, Andhra Pradesh, sir.
Okay. So a few of you, most of what I am going to talk about may not be new to Priya, Shahida, and a few others who have not raised their hands already, possibly. But then I hope you will consider yourself part faculty as we go along and contribute to the discussions. What I propose to do is to introduce the subject of palliative care, but I will bear in mind that this is only not aimed at introducing you to the subject, but also remembering that you are going to teach many aspects of palliative care. Most of palliative care is already included in the curriculum now. From 2019, students are supposed to learn these things. Pain management, not only 8COP, pain management, end-of-life care. End-of-life care, naturally, that warrants control of all symptoms also. And attitude, ethics, and communication. Unfortunately, faculty of the 703 or whatever medical colleges in the country have not been trained in palliative care. Of the 703 medical colleges in the country, only about 40 to 45 are likely to have any palliative care services at all. But we are going to teach it. But I have this secret desire, secret hope, that you will not only learn this so that you can teach. I'm hopeful that you will get sufficiently interested in it, in the subject, to initiate palliative care services in your own institutions. Because your future patients, including me as a potential patient, will very much need this. Amongst these 54 people that seem to have joined this group today, at least some 20 or at least 15, I'm sure, would have had the experience of a member of your own family going through a serious illness. Maybe prolonged illness, maybe not. And possibly living with it now, or having lost a life. If I give you half a minute to think, would any of you, amongst you who have had that personal experience in your own family with a serious life-limiting illness, would any of those people like to share that? I mean, not a whole case history, just in 2 or 3 minutes, share what the experience has been. So as a guest, if there are 15 people with that experience, some of you may not be able to talk about it. That may be such a raw wound that you are not able to talk about it, that I understand. Speak only if you want to, but anybody wants to share your personal experience now.
So my father
Who
suffered.
is speaking? Sorry, Priya.
Yes, sir.
Priya, where are you from?
Sir, I am from New Delhi, Dr. RNL Hospital.
Okay.
I'm working as associate professor in
In-
anesthesia there.
In anesthesia. Okay.
So in 2019, in January, my father was diagnosed with CA lung stage 4.
Sorry
And
to hear that.
he was there with us for 10 months. And in November, we lost him. And throughout that time, after he was diagnosed, he underwent so many cycles of chemotherapy. And I somehow at that time I was not that much into palliative care, so we did not give him the palliative care he needed, I think, at that time. And that somehow actually pushed me towards this branch, this field. Mm, and I think he deserved that, but somehow we were not able to give him palliative care, and he underwent chemo, and then we lost him. He was in ICU at that time, last stages. And after that, I thought that I could have done things differently. I could have managed things differently. So,
Priya, it is not easy to share this. It must be very, very painful as you rake up those memories. Wound becomes raw, very raw again. I'm thankful to you for sharing that for the benefit of all of us. Priya,
yes, sir.
you said you knew enough to do things differently. You are a medical professor yourself. You are in the capital city of the country with the best of healthcare facilities. Yet you say that possibly things could have been done differently. What was missing, Priya? At any point, if you think you are a bit overcome, don't want to talk anymore, I will understand that. Just indicate that. But what was missing?
Actually, so many things were missing on the emotional and spiritual level, because we did not reveal to him his stage of his disease. And I think after, we could have made his life much more peaceful and easier if he would have known that. He could have gone to his hometown, back to his the native place. He was in Delhi with me. So I think he could have, if he would have known, he would have chosen to go back to his native place and spend time with his beloved people, friends. He would have said goodbyes to his people. And so many things are there that he could have done.
Priya, that brings up another question. Do you think the medical system has a responsibility to look after these emotional and spiritual aspects of care also?
Yes, yes, definitely.
You believe it? The medical system has a duty.
Yes,
But as a doctor, hey, where did you do your MBBS
Jabalpur,
and MD?
Jabalpur.
So, in your medical education, which was certainly a generation after mine, for both of us, the medical education was only to diagnose and cure. Okay, some kind of prevention was taught. But who on earth learned about emotional and spiritual care? Is Priya being a bit unfair, doctors? Is it your duty? Dr. Nasia Khan, Dr. Satyendra, Dr. Vaishnavi, we have been taught to diagnose and cure diseases. Priya is expecting us to attend to emotional and spiritual issues also. Is that possible? Is that our duty? Anybody? What do you think?
Yes, sir. It is definitely our duty to address their concerns. So it is very important that we actually look the patient as a person. So we have to see the person as a whole rather than looking the patient as a patient.
Thank you, Vaishnavi. Where are you from?
So I'm from Marni, from Vellore, Government Vellore Medical College.
Thank you, Vaishnavi. Vaishnavi is underscoring what Priya said. The fact remains that you or I, when within our MBBS or possibly in our MD, we are not exposed to anything but physical aspects of the disease. We started with our anatomy and we understanding the body, only the body, not the mind, not the spirit, the body. All the background knowledge in pharmacology, microbes, oh my God, so much about microbes and pathology, everything, but not about human beings. Now, there is an issue that I brought up. Is it the doctor's duty to look after emotional and spiritual factors also? And Vaishnavi says it is our duty. But is it really? What is the doctor's duty of care? I mean, till I came into palliative care, which actually was when I was around 40. Till then, I had never asked myself question, what's my duty? And I had seen it as treatment of the issues in the body, nothing more. Now, our natural humanity may make us go into something else, but that's not what we were taught to do. Let me share my screen and share some thoughts with you. Oh, I'm sorry. I brought up the wrong presentation. Here. Can you see the screen? Here is the official definition of the duty of the healthcare provider from the Bioethics Unit of Indian Council of Medical Research. Shahida, can you please read it out aloud for all of us?
The duty of the healthcare provider is to mitigate the suffering, to cure sometimes, to relieve often, and to comfort always. There exists no exception to this rule.
Are you able to accept this? We have a
Yes,
duty to mitigate suffering.
Mhm.
Unfortunately,
Yes,
you and I were not taught that, but you now have the opportunity to do it for the students. MBBS, 2019 onwards. Every batch can learn this. We are learning to mitigate suffering. And at some point of time, I'm sorry to say that this need becomes important in our own lives. When someday or other, our loved ones also will become ill. And at that time, we need this knowledge, and your students need this knowledge. Sri Priya will be sharing this presentation with you. I would recommend that you go to this link and read at least the executive summary. Now, we will talk about the World Health Organization's definition of palliative care. But first and foremost, before going into that, I hope you will accept this definition, this description that came out of a more recent document, 2017. This Lancet Commission report talks about palliative care as the mitigation of serious health-related suffering. Even if you do not read the other document, it's okay, but certainly read the executive summary of this document. I'm not asking you to read the whole document, which is 56 pages, but it's available for free download. Download it and keep it on your disk. You will need to come back to it from time to time as you move forward in your career. So tomorrow, somebody asks, what is palliative care? You do not have to try to remember the 1.5 kilometer long WHO definition. You can just say, we palliative care people treat suffering. We mitigate suffering. We prevent and treat suffering. Health-related suffering, which is what is seen in Priya's space even now. And the numbers are huge. According to this Lancet Commission report, 7 million people in India are suffering only from 20 different conditions. There are many that are left over. It's not talking about the surgical pain, the burns, the intensive care. Sorry. The intensive care needs or anything like that. That's why I say 7 to 10 million. And today, less than 4% of them in India has access even to basic pain relief. More than 96% of people are destined to be in pain, and which is what Anil Kumar, Harsha Patel, Bhanu Prakash, Rachel, Vijay, all of us together, we are going to address that. The nature of suffering is okay. Vijay Ramalingam has already accepted the responsibility. Very good. Thank you, Vijay. Vijay, where are you from?
Sir, I'm from Coimbatore.
Which institution?
KMCH Institute of Health Sciences and Research.
Which one? Which one?
KMCH Health Sciences.
KMCH, okay. So, in addition, please remember this. Priya is a medical professor. Maybe her family could afford it without much problem. But look at the numbers. 55 million Indians are destroyed by catastrophic health expenditure annually, according to this 2018 publication by 3 Indian authors. My God, gentlemen and ladies, you see 55 million, that's more than 4% of our population. What are we doing? We are supposed to mitigate suffering. And in 1 year, we are making more than 4% of the population go below the poverty line. What kind of healthcare is this? 65% of healthcare in India is in the private sector. Only a tiny minority of Indians have insurance. These are the realities. Now, I am sure you will not be able to remember everything that is shown here. This is the breakup of the conditions that are likely to cause serious health-related suffering. The majority doesn't include everything. But see globally, according to this estimate, true, leukemia and other malignancies together, 28.7% is the largest percentage as a single entity. Next comes HIV. See what comes close behind? 12.2%. Dementia. Is there anybody in the group who has close association within a family member in dementia? And if yes, would that person like to share what that experience is like?
Yeah, good evening, sir. Actually, my father.
Did somebody
suffered-
speak?
Yeah, I'm Dr. Rukmini.
I can't hear you. Let me increase my volume. Can others hear?
No, it's very feeble.
Ah.
Is that
So-
clear, sir?
Yes,
Yes,
yes.
it is. Is it Dr. Rukmini Devi?
Yes, sir. Yes, sir.
Dr.
Actually, my
Rukmini, where are
father-
you from?
Kakinada, sir. Rangaraya Medical College.
Okay.
My father suffered with dementia. Really, it's a very big problem for us. He used to go somewhere and we used to make him back, or somebody else who knows us, they will take my father to us like that. Really, we suffered with that. After that, during COVID season, he expired. That is the thing. Sorry to say.
Dr. Rukmini, I'm sorry. I mean, I'm truly sorry that you had that experience with your own father, because let me ask you a question, Dr. Rukmini. Again, it can be a painful question, but you must have seen numerous people with cancer. Maybe somebody in your own family, maybe not. But between dementia and cancer, which do you think causes more of suffering?
Physically and mentally, both are same, sir. I feel that mental suffering is more painful. Uh, Maybe more painful than physical, what I feel. But actually, why I am interested in palliative care means my neighbor, she's CA cervix, my just opposite house, and she had a total colectomy. Oh, really, I'm feeling bad, very bad about her, because she used to talk with me nicely, and she didn't reveal. After long time, I came to know that she undergone total colectomy. I thought this palliative care, maybe I may use her for her. To relieve her anxiety or emotions. So for that purpose, really, I wanted to learn, more things from you. Thank you, sir.
Dr. Rukmini, this patient's neighbor, you said,
Yes,
is
sir.
in which city?
Here only, sir. Kakinada.
Kakinada. Dr.
Yeah.
Rukmini,
Just opposite
because
my house, my apartment.
this course will go on for several days, but her care need not wait till then. Sri, will you please share our telehealth number with the team on the chat box for anybody?
Sure, sir.
Dr. Rukmini, we have a telehealth program. We can
Yes.
start doing what we can right away. If a
Okay, sir.
family member will ring them up and
Yeah.
give the details and make a registration, we will continue to work on that. I mean, we did not wait for you to finish the course, but we could get started right away.
Yes, sir. Thank you so much.
Sri,
Yes.
I'll forget all this. Sri, please remember to follow up also.
Thank you so much, sir.
Dr. Rukmini, you said both. Personally, having seen both,
Sir?
if God, sorry. No, I was saying that personally, if God Almighty came to me and said that, hey, Rajagopal, you have to choose between cancer and dementia. There's no way. If he forces me to, I'll choose cancer.
Yes,
This
sir.
suffering is unbelievable. Anyway, so I was showing you the numbers.
Yes, sir.
See, friends, all
Yes,
this is yes, Dr. Rukmini?
Sri Priya, sir. Sri Priya,
Sorry,
ma'am.
sir. Sorry.
Yes, that numbers I will take from Sri Priya,
Okay.
ma'am.
And she will put it upon the chat box.
Already
Yes, sir.
shared, sir. It is
Shared.
available in WhatsApp.
It's on the chat box. So, friends, look this up. Majority cancer, then comes HIV, then comes dementia, but other neurological diseases, and also cardiac, renal, liver, so many, musculoskeletal. Palliative care is for everything. Many of you might have had an association in your mind between palliative care and cancer. Many of you may have had an association between end of life and palliative care. No, and no. Palliative care is for all serious health-related suffering. And we live in a country where more than 29,000 people in India kill themselves for health-related reasons. 1/5 of all suicides in the country are caused by serious illnesses. But there is more to it. I told you that 55 million people are driven below poverty. Now, who is going to be kind enough to read this out for me? Dr. Bhanu Prakash, would you like to? Where are you from, Dr. Bhanu? Please unmute yourself.
I am from Karnool Medical College, Karnool, Andhra Pradesh, sir.
Hello, Dr. Bhanu. Would you like to read this, these few lines from Dr. Sankha Mitra, an oncologist of Indian origin, now working in Australia but doing charity work in India?
Yeah, sure, sir. In India, the poor die in misery of neglect, the middle class die in misery of ignorance, the rich die in misery on ventilators, and no one gets a pain-free and dignified death.
Sir, Priya earlier said her father died in an ICU, and she wished she was where he wanted to be. For most of you are very young people, and it will not be easy for you to think about your own end of life, but it's very easy for me. I can see it right there in front of me. And when my time comes, I want you. I don't know who is going to treat me. Shirley or Anjana, if you are going to look after me, please remember, please make me comfortable physically first. If I am having overwhelming pain or breathlessness, I will not even be able to think. But once you have made me physically comfortable, remember what would be the most important things for me. None of these machines would have any value. I myself have been an intensivist. I know that it is valuable for correctable disorders. If I have a flail chest with an accident, even at this age, it's okay. Take me to the put me on life support and save me. But if it is cancer, if it is dementia, if it's one of those other conditions, the only thing that matters to me is the love that I'll get and the love that I'll receive. And none of the machines can do that. Do you know about the National Cancer Grid? Is there any oncologist in the team? Please raise your hand if there is. Sri, can you see anybody?
Not yet, sir.
The National Cancer Grid is a collaborative of cancer hospitals in the country. Most probably, most of you, your own institutions, oncology departments would be members. And together, the National Cancer Grid has made this recommendation. This was published in the Lancet a few years back. fairly recently. You can't remember which year. I should put that also in. Do not treat patients with advanced metastatic cancer in the ICU unless there is an acutely reversible event. Yet, in India, see this right-hand panel. This was published by Dr. Rajkumar Mani, one of the best-known intensivists in the country, living in Delhi. And he did this study recently and published that 70% of Indians who go on intensive care unit and die there, die on life support systems. Most of the other 30% are, okay, LAMA, leave against medical advice. And they are on the life support systems, they are put on an ambu bag and sent in an ambulance, which is very unethical and cruel. Whereas in Western European countries who are supposed to have the best healthcare systems in the world, certainly we are not talking about the USA, Australia, or Canada, but Western European countries, 90% of patients, if the disease is not curable and if return to reasonable quality of life is not feasible, are taken away from life support systems, instead given palliative care to make them comfortable. And this doesn't, exactly the opposite happens in India. In India, maybe India and our other South Asian countries are the unique places where this cruelty happens most. I am saying that because these are things that Suraj, Sindhya, Taval Kumar, Tejarban, we have to change this. We have to change this for our own loved ones back in our homes and for ourselves. We have to recognize that suffering, as was mentioned already, can be not only in the physical domain, but in the social domain, like relationships, poverty, emotional domain, the anxiety of not knowing what's happening to them, the depression, the guilt, and spiritual, not necessarily related to God, but also could be related to God. Oh, why did God do this to me? But also the loss of meaningful of life. Every 3 days I go and at least every 3 days I go and visit my younger sister. And practically every time she asks, how much longer? How much longer has this to go on? She smiles and then still says, I wish this would end. That's a spiritual suffering, loss of meaning in life. All these are problems that we have to learn to address. And that we will, as the course goes forward, talk about how we can alleviate the suffering as much as possible. All suffering cannot be alleviated. We will have to accept that. The situation is bad. It will be bad, but we can make it a lot better than it is. That's what we'll try to do. Sorry, ladies and gentlemen, that is the long WHO definition. I apologize for the definition because it is too long. Definition should be nice and crisp. This is 21 years old. An approach that improves, it's about quality of life. Let us pick up some of the aspects. Quality of life, not only quantity of life. Not only the patient, but also the family. Not only for her father, but also for Priya. In association with life-threatening illness. Now, here is a catch. How will you define life-threatening? How will you define life? What is life-threatening? Let me give you an example. Suppose somebody has a spinal injury. You know that most spinal injury, More than 80% of spinal injuries happen in young men between the ages of 20 and 30. Falls from trees, fall from construction sites, motorbike accidents, etc. They have a life-threatening illness? Maybe not in a European country, maybe not in USA, where the spine will get fixed, the person will be rehabilitated, and in a month or two, you will see them in their own office, wheeling in, or in the supermarket doing their own shopping. There it may not be a life-threatening illness, but here, think, what is life? Is it only existence? Is it only a beating heart? Or is it something that involves some enjoyment of life? Some contribution to others' lives? So, many things that may not be life-threatening in other countries may be life-threatening in our countries. And I'll go back to the screen and share the definition again. Prevention and relief of suffering. It does mention that by treating pain and other physical problems, psychological problems, social problems, and spiritual problems. I'll briefly stop. I'm not done yet, I know, but I'll stop there just to see if anybody has any question about what was talked about so far. Sridevi, am I right in assuming that there is no case presentation today?
Yes, sir. Yes, you're right, sir.
Okay. So, friends, any questions about anything that I have talked about so far? I'll be silent for 30 seconds to allow you to think.
Sir, can you hear me?
I can hear you.
Yes. Sir, I'm Dr. Anirudh from KMCH IHSR Coimbatore.
Hello, Dr. Anirudh.
Sir, my query was regarding in the palliative care definition, they say that there is something called as impeccable assessment and treatment of pain. What is impeccable here, sir?
It is very interesting that you picked up on that. Most people do not. But this is the two words there have been most criticized. And you picked up on the first most criticized word. Impeccable is faultless.
Exactly.
Is that achievable?
Exactly.
We are human beings. That may be achievable in about 50 years from now when artificial intelligence have advanced so much and perfectly functioning robots take over, but not possible. And that was a totally unnecessary word. Very sharp of you to identify that. That and life-threatening are the terms that were most addressed, most criticized. If I were WHO, I would apologize for that word. Anybody else? Shirley's face tells me that Shirley is thinking very hard. You have something that you are thinking about, reflecting on. Would you like to share that?
The same thing. The same thing.
Okay, okay. Two sharp people. Okay. So let me go back to my screen and continue unless somebody has a question or a comment. Any comment? Last chance. Now, when will palliative care start? The same definition that we have been criticizing very sensibly made this statement that it is in the footnotes. The definition has 9 footnotes. One of them is that palliative care is applicable early in the course of illness, in conjunction with other therapies that are intended to prolong life, such as chemotherapy or radiation therapy, and includes those investigations needed to better understand and manage distressing clinical complications. Again, 2 long sentences. But look at the first line. It's applicable early in the course of illness, in conjunction with other therapies. Priya, can I ask you, when do you think your father really needed palliative care along with his cancer treatment?
So when he was diagnosed first.
When somebody is diagnosed, the way it is communicated can make or break a human being.
Yes.
Priya, so are we saying that even before starting the treatment, every patient with a serious illness should be referred to the palliative care unit?
Yes, definitely, sir.
But Shirley is shaking her head. Shirley, why are you shaking your head? You don't agree.
Sir, till they are diagnosed, I don't think we can refer them to palliative care. No?
Shirley, I agree. Priya, do you think that's practical? Every single illness, serious illness, right from the beginning, referral to a palliative care unit? Is there anything?
We can incorporate this idea of
there it is.
holistic treatment. If we make people aware of this holistic approach, so why not, sir? If we
Shirley, how about that? Every doctor and every nurse knows the fundamentals of palliative care and incorporates it into his or her own treatment.
Then it will be a good thing, sir.
But that's what you are going to do. Every medical student is going to learn all this from you. See what an important task you have.
Yes.
Not only to teach for the 3 classes assigned to you, but to be catalyst for a change in your own institution, to make sure that every department concerned, Sridevi, I'm sure will talk to you more about it. There are 20 modules there that are related to palliative care. They'll be taught in so many different specialties. But I hope everyone here will be a catalyst in your own institution to make sure that in the whole institution, palliative care gets taught, so that somebody with a suffering like Priya's dad will get the appropriate treatment from the oncologist. The way he or she communicates to the person, what's happening, the way explanations are given, the way the person looks at the patient with compassion. So, Shirley, the answer I agree is not, we'll talk more about this integration that Priya is talking about.
Yes.
How the medical system will integrate palliative care into all healthcare. And then a palliative care physician like you may have to come in only for difficult problems. Do you think this is a pipe dream? Is it possible? I can tell you it's already happening. We'll talk about it. So, palliative care has to start not necessarily with a referral to a palliative care unit, but by every doctor and nurse and social worker and physiotherapist incorporating principles of palliative care into his or her practice. And at one time we thought when curative care ends, palliative care will start. But now we know better. Both have to start concurrently. In the beginning, the relevance of the palliative care may be limited. As Priya mentioned, maybe only communicating the bad news and treating major symptoms. But as the disease advances, the palliative care aspect will become more and more. And remember, palliative care is not only for Priya's dad, it should be also for Priya and for her mother and for her siblings. It is for the family also, and therefore it cannot end when the patient dies. It continues as bereavement support. Is that clear, or is there any question? We are not going to talk about the details of pain management now. But this is the World Health Organization's 3-step analgesic ladder. See how many years back it was advocated? I'm not good at math. 37 years back. And even today, while it has dramatized pain management all over the high income countries, in low and middle income countries like ours, where 86% of global, 84% of global population lives, it is hardly available. In India, as I said, less than 4% of the needy have access to pain relief. And step 3 opioids. This is your paracetamol and NSAIDs, and maybe the tricyclics or anticonvulsants for neuropathic pain. And then you add something like tramadol. But then we come to morphine or medicines of that class that is available to less than 4% of the needy in India. That is something to change. Now, in 2014, the World Health Assembly, which is the decision-making body of WHO, came out with this declaration, which I have attached here. I have given the link here. They asked us to do something that Priya asked for just now. Integrate palliative care into all healthcare. Integrate palliative care into health systems at all levels. Primary, secondary, and tertiary levels of care. Across the continuum of care, from the beginning of the suffering to the end. You may think that this is not possible. This is not achievable. I agree that it will take time, but it is achievable. And you have the power to do it. Your own institution, if it does it, 100 doctors or 200 doctors every year are going to pass out learning the basic principles. Similarly, this education, the way you are going to teach, learn and teach, will mean humane and symptom control. Sorry, Priya, if I am hurting you more by saying this. But if tomorrow when my time comes, I have advanced cancer and I am breathless, I don't want the ICU, I don't want the ventilator. As I said already, if it is flail chest, I want it. But in this case, I don't want it. I want my wife with me to say a final word of farewell. I want to be able to hold on to my son's hand if he is there. And most precious, I want a kiss from my grandchild. Tell me which intensive care unit will allow that. Intensive care is a great boon for salvageable issues. It's an Indian disease which happened only in the last 20 years that it became the standard of death for the rich. I want no false reassurance. Just tell me, hold my hand and tell me, Rajagopal, we will do our best to make you comfortable. The very feeling, friends, this is important. Whatever your specialty is, already 2 people said they were anesthetists. When you see that anxious patient trembling with fear on the operation table, before you are ready to put on the monitors, okay, take 10 seconds, hold a hand, say, I am so and so, I am your anesthetist. I am going to look after you. I am going to make sure that you are okay. Imagine the flood of warmth and relief that will go through the patient. To know that somebody cares. There's a human being looking after me, not only machines. Similarly, the oncologist looking at the patient with compassion and saying, I'll do the best for you. Don't promise the impossible. Don't promise that I'll cure you. You may not be able to. Promise what you can. But this is great. Assure to do your best. Do you think in advanced cancer, oxygen will always help? Friends, will it help? Advanced metastatic cancer, lungs full. Will oxygen inhalation help? What is your objective? It is not to increase the oxygen saturation from 72 to 76. Objective has changed. The pulse oximeter is a nuisance now. Your objective is to make me feel better. If I am not feeling better, your oxygen is of no use. It is a harm. It's a nuisance. I can't even communicate. I'll feel very hot there. I'll feel more suffocation. Anesthetist, please tell me, reflect on your pulmonary physiology. How long does it take for the inspired oxygen, inhaled oxygen, to equilibrate with the arterial blood? If I start 60% of oxygen, how long will that equilibration with the arterial blood happen? Most of it will happen in about 3 to 4 minutes, but it will be complete in 7 minutes. So what I do to such patients, I'll tell you. I'll say, you will have more on breathlessness later, but this is just the introduction. I'll tell them, I am going to put the oxygen on your face. I'll try it for 10 minutes. If it makes you feel better, we will continue it. If you don't want it, we'll take it away. There is no point. If it is not making me feel better when I am in the last stage of life, what is the point? Of course, the family will, hey, doctor, aren't you going to give oxygen? Of course, they also will have to be given the explanation. So, I'll do only what gives benefit to the patient unless the patient himself is a doctor or nurse, or if the family member is a doctor or nurse, they'll be very worried, and in which case I may compromise there, but not on the ventilator. What I may give relief with most maybe corticosteroids and morphine. Corticosteroids. It will not give immediate relief. It will take a few hours to act by reducing the peri-tumor edema or reducing the edema in airways and COPD. It is likely to give relief. But morphine, to that patient with advanced metastatic cancer, breathing like that, will you give morphine? Should you give morphine? I did my MD in anesthesia in Delhi. In my final exam during the Viva, the examiner asked me, tell me one major contraindication for morphine. I said dyspnea. And the examiner said, very good. The answer was correct at that time, not anymore. If you look up the guidelines of American Thoracic Society, you will find that as among the drugs of choice for terminal breathlessness, the first one is morphine. Certainly not 15 milligrams shot into the vein. Very tiny doses. We usually start with 2.5 milligrams 6 hourly, orally, which may be the equivalent of 1 milligram parenterally. But with that is not enough to cause respiratory depression and apnea, but that may be enough to suppress the respiratory center so that the person loses the sensation of breathlessness. You can see it visibly. patient's breathing will become easier. Those who remember the respiratory physiology from those days will remember that when the patient with some obstruction in the airways tries to breathe harder and harder, the airways collapse more. Breathing is less efficient. And if you just tell the patient, slow, slow, they may not be able to, but morphine will achieve that. What I'm saying is, I'm not going to talk about all symptoms. The point is, the symptom control that you learned in acute medicine or acute surgical practice may not be relevant here. What may be relevant here is my comfort as a patient. So friends, here's a poll for you. Sripriya, are you ready with the poll?
Yes, sir.
Please tell them what to do.
So everyone will get a prompt on your screen with a question. So you have to choose which one you feel is the most appropriate. There is no right or wrong answer. So whatever you feel appropriate, just choose that and submit the poll. Launching the poll now, sir.
Thank you. Forty-four people have responded. 45. Nobody.
Team had gone twice. First team was cardiologist along with the medical officer in Godwin. So they were there in Chushchanpur for 2 weeks. Details Godwin may be able to. So what they had done was medical camp.
Your voice is breaking and dragging. We are not able to follow you.
Dr. Priyadash, are you trying to communicate with us only?
There was a side conversation.
Yes, sir, I guess so.
So 47 people have responded. Nobody said only at end of life. So thank you very much. Absolutely correct. The two people who said when disease is incurable, I don't know who the two people are, but please change that answer hereafter. If I am your patient, I don't want to wait till you have declared my disease incurable. I need pain treatment now, from the beginning. I would say the first two answers are totally acceptable. At the from the time of diagnosis, what the WHO definition says, the footnote says, but this is what I would like most, even if you have not arrived at a diagnosis. Please treat my pain for the time being. Treat my suffering. Tell me, I see you are anxious. We are trying to do your best. So these two are the best answers, and of them, my personal preference would be for this. But I am not going to argue with the 35 people and the WHO together. So at the time of diagnosis, also acceptable. But once more, those who said when the disease is incurable, no, very clearly not. We should not wait till then. Palliative care has to start when the suffering starts. So we will not only look at the pain and breathlessness, but all symptoms and also emotional, social, and spiritual suffering. So if we already mentioned that the World Health Assembly asked us to integrate palliative care into health systems at all levels across the continuum of care. And that means integration of palliative care into all healthcare. You already mentioned that earlier. Every patient at every time of illness cannot go to the palliative care unit. Certainly, the public awareness is necessary, the community support is necessary. The Priya mentioned her dad wished her dad could have gone to the countryside along with the patient, along with the family, and spend time where he wanted to be. But in that case, unless the local community understands what is happening, they may come and say, "Hey, Dr. Priya, what a cruel daughter you are. Here, take him to the West Hospital, take him to Apollo." So they also have to be supportive. And that's something that we all must take as our duty to make the public aware of what we are doing. But palliative care is to be integrated into all healthcare, and only difficult issues need to be brought up to the palliative care units. Such integration can be at my macro level. That's a national policy. Meso level, at the level of hospitals. Micro level, one department or individual. What do you think is happening in our country? Are you able to see my screen? Oh, sorry, my screen was not visible, right?
No, sir. The presentation is not there.
So I'll show that slide again. Oh, come on. I said earlier, that the integration has to happen so that all healthcare providers will be able to do it to some extent. The community will be supportive, and the palliative care units need to see only particularly difficult problems. And this integration can happen at the national level, macro, meso, or micro level. Friends, do you think this is possible in India? What do you think? Are we ready to do it? I can tell you that this is already happening. From 2012, a national program for palliative care has been on. It has not been very effective, I'll admit. But the 2017 National Health Policy already includes palliative care. Not only it is policy, it is practice. In the sense, over the last 3 years, the National Health System Resource Center of Government of India has conducted training for national level trainers and state level trainers. Sridevi and Shiva spent a lot of time working with them all through the COVID season. And national level and state level trainers have already been trained. We are set to move forward. It's part of health policy. And the NDPS Amendment Act of 2014 is facilitating access to morphine, so that all of you, after this course, if you do not have access to oral morphine, will be able to access morphine, and we'll work with you to make it happen. And also, even more importantly, I would say, see the bottom panel. Undergraduate medical and nursing curricula now include palliative care. And that's phenomenal, which is why we are all here. You all are going to make a lot of things happen. In another few years, medical students coming out of your college will not be just prescribing ibuprofen on TAD and leaving the patient alone. They will scientifically evaluate the patient and treat symptoms. And me, to a large extent, provide emotional support. Sri will possibly tell you more about much of this later. But there are 20 modules under 12 themes related to palliative care, distributed from the pre-course foundation course to internship. Different departments will be teaching it, anesthesia will be teaching pain, ethics will be taught by somebody. But wherever that is, I hope you will be the catalyst in your own institution and make it happen. You should know that Sridevi and colleagues have already made this course possible. There is a massive open online course on Palliative website which you can access. Anybody, any healthcare professional can just register and it will have all the necessary documents. We have a promise from Kerala University of Sciences that they will work with us. We'll develop. You are part of a faculty development program which we'll scale up, and gradually we will have the message of palliative care go through all medical faculty and all medical students. When I say we, you and Sridevi and we all together. I see that we have more than 15 minutes left. I'm sorry, this has been such a long session, but we have more than 15 minutes. Sridevi, can I hand it to you for the discussion? I'll stay here. I'm available.
Sure, sir. Thank you everyone for your patient listening. As you might have understood, you are a part of a very bigger program and a bigger vision in integrating palliative care into medical education. We're happy to take a few questions from any of you.
Sir, good evening.
Good evening, Doctor.
This is Dr. Sitaram, sir, from Coimbatore. So not
Dr.
a
Sitaram, which institution?
It's a KMCH Medical College.
Okay.
I'm heading the Department of Community Medicine. So this is more less of a question and more of a thought sharing, sir. A couple of us have joined me, Anirudh, who spoke earlier, in the hope of seeing how we can bring in a community-based twist, a development to palliative care. And by community-based, I don't mean the usual image of a poor rural household. Basically, outside the hospital, a home-based element to palliative care. That is what we're trying to see. I'm new to the whole area of palliative care, but that is what we are interested in checking. Outside the hospital, home-based care or interventions. I'm just saying this now because upcoming sessions may be very specific and focused. This being a very broad-based, know your course kind of discussion, I'm putting this here. This is one of the reasons we are here, sir.
Fabulous.
Yes,
Dr. Sitaram, I'm so glad that you are here, head of Department of Community Medicine. People who go out into the community, and your interest in this is so precious. I would invite you and Anirudh just to come over and spend a few days with us. Coimbatore is right across the hills, on the other side of the hills. It's not far from yours.
That is true.
Just come over and see how we get the community. Not only community outreach, Dr. Sitaram, not only reaching, providing care there, but also getting the community involved also. And you are experts in this, and this approach of palliative care also. Sridevi, please remember this. We should dust the red carpet and roll it out to Sitaram and Anirudh so that they'll actually be able to see. We are very keen on this. We have a facilitation team. Sridevi, will you please also introduce them to Shalini and Lilith so that our facilitation team can work with them? Let us make this happen. Yes, Doctor. The Asthana Declaration, which even if nobody else knows, the community medicine people will know. Asthana Declaration is a declaration by world nations all together, created in 2018. Asthana is the capital, not the Mr. Asthana in Delhi. Asthana is the capital of Kazakhstan, where the declaration was signed by all countries, including India. And one of their messages was, healthcare should reach people where they are when they need it. Priya was expressing their hope, wish that her dad could go to the village or wherever he was. But he would still need healthcare there. Not everybody has a very capable daughter who is a doctor. Healthcare has to reach people where they are when they need it. So, Dr. Sitaram, we see our job not only as treating the patient's intervention and not only in running courses. The follow-up is important. To any of you, our teams will work with you to sort your problems out. So you would have problems. We have made all possible mistakes and learned from them. So if you have a problem accessing morphine, if you have an problem with a few questions about drug availability or community participation, let us share our experience and work with you.
Lovely, sir. That will be very nice. Thank you.
Thank you so much, Dr. Sitaram. I'm adding on to what Dr. Rajagopal told about linking you with the facilitation team. We have one of our global fellow from your own institution, Dr. Punitha from anesthesia. Sir, he works with Dr. Punitha.
Okay.
Yes, we spoke to her actually. She was, we spoke to her before we started the application. Yes.
Okay.
And we have 7 teams going out every day, 5 days a week, catering to around 6,000 patients in the community. So if you can find some time to visit us, we'll be happy to take you around and show how we do the community involvement in linking, as what Sir said in his presentation, the micro level and the macro level, how we link through the community volunteers.
Most definitely, ma'am. Looking forward to.
Any other questions? And that invitation is not just to Dr. Sitaram. Any of the participants, we are happy to have you here with us for a few days to be a part of our clinical services. Any other questions or comments?
Shahida says we are running palliative care electives for CBME. So maybe Sridevi, we may have a few lessons to learn from her also, sharing experiences. Shahida, how do the students receive this different kind of education?
Yes, sir. Actually, I told them before itself, it is nothing like so much glamorous like the other subjects and all. But still, after going through the lessons, they became little more empathic, like towards especially the cancer pain OP that we see, which was initially started by Dr. Kameswara sir in Kakinada. And Kameswara sir had been trained under you, sir.
So Dr. Kameswara, long-term friend of mine. How many years?
Yes,
At
sir,
least
yes,
30
sir.
years
I
old
have been
friends.
trained under him. Yes, sir.
I see. Okay.
Yes, sir. Yes, sir. He started the pain clinic, sir. That's
I know. So please say hello to him.
So slowly we have introduced the concepts. Yes, sir. Yes, sir. Yes, sir.
As Sripriya mentioned in the chat, you will have access to all these recordings through your ICO platform. We'll be sharing materials. And if you need any other readings or any other assistance, just reach out to us. We'll be happy to provide, share whatever materials we have.
Sri, also will you provide the link to the Indian primer, if not already done?
Yes, yes, yes.
And that's also a print book. Those who prefer to read, if you don't want to strain your eyes so much, invest 300 rupees and a copy will be sent to you. The print version of the Indian Primer of Palliative Care. I recommend that you access it, either soft copy free from our website or the print copy on payment of the enormous amount of 300 rupees.
Thank you so much, sir. If there are no more questions, maybe we can wind up today's session.
You are the most, Sri.
Thank you, sir. Thank you all the participants for being with us. Tomorrow we'll be listening on discussing about pain. Pain has more than one session. So tomorrow we'll start with the pain management session 1. And see you all at the same time tomorrow, 5 o'clock. And thank you so much for being part of this program.
Thank you.
Thank you, everyone.
Have a great evening.
Just a humble request to everyone to please join us at 5 itself so that you don't miss the initial important parts. We do know you all are very busy people. Your duties might not get end at the nick of the time, but still, as far as possible, please try to log in at 5 itself. So with a promise that we will meet again tomorrow, this is Sripriya along with the Dr. Rajagopal and Dr. Sridevi signing off from the Tipsy Co.
And Sri, let me add one word. And from next time, please switch on your videos, everybody. I know that some people may have a minority people may have a bandwidth problem. Please, it's important to connect with a face for the speaker and for you to connect with the speaker. Please try to switch your video on from next time. Thank you very much.
Thank you, sir. Couldn't agree much more. 100%. Thank you.
Sri.
So thank you, everyone. See you tomorrow. Till then, everyone take care. Keep spreading happiness. Bye-bye.
Thank you.